At night, the heart works in darkness, folding a lifetime of effort into each quiet beat. Most of us notice nothing as blood crosses chambers, valves, lungs, and arteries in seconds. Yet heart disease rarely begins with a dramatic clutch of the chest beneath a flashing ambulance light. It often begins silently, years earlier, in pressures, particles, smoke, sugar, sleep, and circumstance. The phrase heart disease sounds like one enemy, but it names a crowded landscape of disorders. Coronary disease narrows arteries, arrhythmias disturb rhythm, and damaged valves misdirect flowing blood. Cardiomyopathies weaken heart muscle, while heart failure leaves the body inadequately supplied or congested. Congenital defects begin before birth, and rheumatic disease can follow an untreated bacterial infection. These illnesses differ, yet many converge on one question: what has the heart endured over time? To answer it, we must travel upstream from the emergency and watch risk accumulating in silence. Imagine entering a healthy artery where blood glides past a living wall thinner than it appears. The wall senses pressure, exchanges chemical signals, and constantly adjusts the vessel's width and tone. Into this current travel, lipoproteins carrying cholesterol, an essential substance with dangerous potential. Particles containing apolipoprotein B can become retained beneath the artery's inner lining. When that retention persists, inflammation follows, and the once smooth wall begins to change. Immune cells arrive, ingest lipid, and help build a plaque beneath the flowing surface. This is atherosclerosis, not grease in a pipe, but an active disease within living tissue. Some plaques grow slowly and restrict blood flow, producing pressure or pain when the heart works harder. Others remain less obstructive, yet become vulnerable to rupture or erosion at their fragile surface. The most dangerous plaque may therefore be the one that gave no warning the day before. When a plaque surface breaks, the bloodstream interprets the injury as a wound requiring repair. Platelets gather, clotting accelerates, and a thrombus can suddenly seal the coronary artery. Downstream heart muscle loses oxygen, and living cells begin to fail and die. That event is a myocardial infarction, commonly called a heart attack. A similar interruption in an artery supplying the brain can produce an ischemic stroke. The catastrophe looks instantaneous, but its biological fuse may have burned for decades. Cumulative exposure to LDL and other apoB particles is causally linked to atherosclerotic disease. The important word is cumulative, because the artery remembers both concentration and time. A modest hazard carried for many years can matter more than one alarming result viewed in isolation. Modern prevention increasingly asks about the path of a lifetime, not merely today's snapshot. Blood pressure creates another invisible history, written as mechanical strain on vessels and muscle. With every high-pressure pulse, the heart must push against greater resistance. Artery walls stiffen and suffer injury, while the heart's main pumping chamber may grow thick. What begins as adaptation can become a trap, demanding more oxygen while relaxing less effectively. Hypertension raises the risks of coronary disease, stroke, kidney disease, atrial fibrillation, and heart failure. It commonly produces no symptoms, making measurement far more reliable than intuition. A cuff around the arm can reveal danger that strength, youth, or outward fitness cannot exclude. Repeated readings matter because pain, stress, technique, and surroundings can briefly alter the number. When high pressure persists, lifestyle changes and medication can substantially reduce major complications. Treatment is not cosmetic correction of a number, it changes the forces reaching vulnerable organs. Tobacco smoke approaches the same system through a different door. Its chemicals injure the endothelium, promote inflammation, accelerate plaque, and encourage thrombosis. Smoking can also reduce oxygen delivery precisely when the heart needs oxygen most. There is no cleansing ritual that cancels this biology while exposure continues. Stopping matters at any age, and cardiovascular risk falls substantially after quitting. Secondhand smoke is not harmless background scenery, especially around people already at risk. Air pollution and other environmental exposures can also add cardiovascular strain across populations. These risks expose an uncomfortable truth. Prevention is partly personal, but never purely individual. Housing, income, work, food access, healthcare, and neighborhood design shape daily possibilities. Advice becomes realistic only when it acknowledges the world in which a person must act. Diabetes and insulin resistance connect the bloodstream, kidneys, nerves, and arteries in another web. High glucose is only part of the story, alongside abnormal lipids, inflammation, and vascular damage. Kidney dysfunction can raise pressure and disrupt metabolism, while heart disease can further injure kidneys. Obesity can contribute through hypertension, diabetes, sleep apnea, inflammation, and abnormal blood lipids. It is also associated with atrial fibrillation and several pathways leading toward heart failure. This is not a moral verdict encoded in body size, and shame is not a cardiovascular treatment. It is a biological network influenced by genes, medicines, stress, sleep, environment, and opportunity. Researchers now describe cardiovascular kidney metabolic syndrome to capture these interlocking failures. The framework is established enough to guide integrated care, while its best implementation is evolving. Instead of treating isolated organs, clinicians increasingly watch the whole connected system. For much of history, physicians could describe the failing heart, but not calculate who was approaching danger. That changed when the Framingham Heart Study began following a community cohort in 1948. Investigators repeatedly measured ordinary people, then waited for patterns to emerge across years. Smoking, elevated pressure, and cholesterol became visible as predictors rather than background noise. By 1961, the term risk factor entered cardiovascular medicine with new force. Risk did not mean destiny. It meant that probabilities could be measured and altered. Later studies refined the picture with age, diabetes, family history, kidney disease, and other signals. Modern calculators estimate chances over defined periods, though no score can foresee one person's future. They support a conversation about treatment rather than issuing a sentence from a machine. The deeper legacy of Framingham was making prevention scientifically observable before disaster arrived. Trials then tested whether changing those observations would actually change outcomes. Blood pressure studies showed that treating hypertension prevents major cardiovascular complications. Lipid trials demonstrated that lowering LDL can reduce first and recurrent coronary events. The 4S trial found that simvastatin reduced events and mortality in people with coronary disease. WASCOPS showed fewer first coronary events among higher-risk people treated with pravastatin. The Heart Protection Study extended statin evidence across a broad range of high-risk patients. These results did more than validate medicines. They strengthened the causal story behind LDL. Benefits vary with baseline risk, treatment intensity, adherence, side effects, and time. Medication decisions therefore belong in individual clinical care, not in universal internet prescriptions. Still, the central evidence is clear. Measured risk can often be meaningfully reduced. Daily habits work on that same biology, though they should not be sold as magic shields. Regular physical activity improves vascular function, fitness, pressure, metabolism, and overall risk. A useful beginning may be a walk that raises breathing slightly, repeated until movement becomes routine. Some people need medical guidance before increasing exertion, especially when symptoms or disease are present. Healthy dietary patterns emphasize vegetables, fruits, whole grains, legumes, nuts, and suitable protein sources. They also limit excess sodium, added sugars, highly processed foods, and harmful patterns of alcohol use. No single ingredient repairs an artery, and no supplement substitutes for a durable eating pattern. Adequate sleep matters because chronic disruption affects pressure, appetite, glucose, rhythm, and recovery. Treating sleep apnea can also matter when repeated nighttime airway closure strains the cardiovascular system. The goal is not perfect living, it is a sequence of achievable choices reinforced over time. Alcohol deserves particular caution because its cultural glow can obscure dose and circumstance. Heavy or harmful use can raise blood pressure, provoke arrhythmias, and damage heart muscle. People who do not drink need not begin for the sake of their hearts. For those who do, health advice must account for quantity, medicines, pregnancy, addiction, and other risks. Stress is equally easy to oversimplify, since it cannot always be removed by an instruction to relax. Chronic stress can influence sleep, pressure, inflammation, smoking, eating, and medication adherence. Social connection, therapy, safer conditions, and practical support may therefore belong in prevention. Small changes become more powerful when homes, workplaces, and health systems make them sustainable. Population policies on tobacco, food, clean air, and accessible care can protect millions at once. The heart beats inside a body, but cardiovascular risk also moves through society. Despite prevention, symptoms still arrive, and recognizing them can change the ending. Heart attack discomfort may feel like pressure, squeezing, fullness, burning, or pain in the chest. It can spread toward an arm, shoulder, back, neck, jaw, or upper abdomen. Shortness of breath, sweating, nausea, unusual weakness, or lightheadedness may accompany it. Some people, including many women and people with diabetes, may have less typical presentations. Symptoms can be mild, intermittent, or mistaken for indigestion, anxiety, or ordinary exhaustion. Sudden concerning symptoms demand emergency help rather than a drive delayed by self-diagnosis. Emergency services can begin assessment and treatment while coordinating rapid hospital care. Every minute matters when heart muscle is being starved of oxygen. Yet absence of classic pain never proves that the heart is safe. Other heart diseases speak in different signals: fluttering, fainting, swelling, fatigue, or breathlessness. Atrial fibrillation may produce a racing, irregular pulse, subtle tiredness, or no sensation at all. Because stagnant blood can clot in the atria, selected patients need medication to reduce stroke risk. Heart failure may reveal itself through breathlessness during exertion, trouble lying flat, or swollen legs. It is not a stopped heart, but a syndrome in which pumping, filling, or both become inadequate. Coronary disease, hypertension, valve damage, cardiomyopathy, arrhythmia, and systemic illness can cause it. Treatment depends on the cause and may combine medicines, devices, procedures, and daily monitoring. Rapid weight gain can reflect fluid retention, though weight changes have many possible explanations. Fainting during exertion, severe breathlessness, or sustained chest discomfort warrants urgent assessment. Symptoms are clues, not diagnoses, and their pattern matters more than any isolated sensation. Valves create another kind of drama, opening and closing billions of times without applause. When a valve narrows, blood must squeeze through. When it leaks, blood falls backward. Age, congenital anatomy, infection, and inflammatory injury can all damage these moving structures. Rheumatic heart disease begins after an immune reaction to infection with group A streptococcus. Repeated or severe rheumatic fever can scar valves, often years before disability becomes obvious. Prompt diagnosis and treatment of streptococcal infection can help prevent rheumatic fever. Long-term antibiotics may prevent recurrences in people with prior rheumatic fever, following clinical guidance. Once advanced valve damage exists, repair or replacement may be required. Its continued global burden reflects unequal access to early diagnosis, antibiotics, monitoring, and surgery. Here, a treatable infection can cast a shadow across an entire lifetime. Technology has repeatedly entered that shadow and changed what survival can mean. Werner Forssmann showed in 1929 that a catheter could reach the human heart, using himself as the subject. Cornand and Richards later turned cardiac catheterization into a rigorous diagnostic method. John Gibbons' heart-lung machine helped make open-heart surgery possible in the 1950s. An implanted pacemaker first sustained a patient in Sweden in 1958. Bypass surgery created new routes around obstructed coronary arteries during the following era. Catheter procedures later opened narrowed vessels and delivered stents without opening the chest. Modern imaging can reveal structure, flow, scar, and function with remarkable precision. These advances can correct anatomy, restore circulation, stabilize rhythm, or extend life. But technical rescue does not erase the disease processes that created the crisis. That distinction explains why the word cure can mislead. Some congenital defects or valve problems can be corrected through surgery or catheter procedures. An infection may be eradicated, and certain rhythm problems can be eliminated by ablation. Yet atherosclerosis, hypertension, diabetes, and many cardiomyopathies usually require continuing management. A successful stent treats a dangerous narrowing, but it does not remove every plaque in the body. Bypass grafts reroute blood, while the underlying tendency toward vascular disease can persist. Heart failure may improve dramatically, sometimes with recovery of pumping function, yet relapse remains possible. Realistic management means reducing risk, treating causes, monitoring change, and responding early. Medicines work only when taken, tolerated, adjusted, and supported by follow-up. Control is not failure to cure. It is often the mechanism by which years of life are protected. Even excellent control leaves unanswered questions because cardiovascular biology has hidden layers. Some people suffer events despite low LDL, controlled pressure, exercise, and prescribed treatment. Researchers call part of this remaining danger residual risk. Inflammation may help explain some events that occur after lipid levels are well controlled. Selected anti-inflammatory strategies have shown promise, but benefits and harms depend on context. Clonal hematopoiesis is another active field, linking age-related blood cell mutations with vascular inflammation. The association is increasingly persuasive, while routine testing and treatment remain unsettled. Lipoprotein, largely shaped by genetics, can raise risk even when standard cholesterol looks reassuring. New therapies are being studied, but a biomarker's importance does not guarantee a simple remedy. Science advances by separating an intriguing mechanism from an intervention proven to help patients. Genes also shape cholesterol handling, rhythm, muscle structure, blood pressure, and congenital anatomy. A strong family history can signal inherited risk or shared environments, and often both. Familial hypercholesterolemia can expose arteries to very high LDL beginning in childhood. Earlier recognition allows earlier treatment, changing the lifetime burden carried by the vessel wall. Yet genes are rarely a prophecy written beyond influence. Environment and treatment can amplify, soften, or redirect many inherited vulnerabilities. Risk assessment may include family history, blood tests, examination, and selected imaging. More testing is not automatically better, because false alarms and incidental findings can cause harm. The right test is one whose result could reasonably change a decision. Good prevention begins with curiosity, but it also requires restraint. A practical plan starts by knowing the numbers that silence can conceal. Blood pressure, cholesterol, glucose status, kidney health, tobacco exposure, and family history form a baseline. Age and prior disease alter what those measurements mean, so targets cannot be copied blindly. A clinician may recommend lifestyle changes alone, medication, or both, depending on total risk. Statins lower LDL, while other lipid medicines can be added for selected patients. Several drug classes lower blood pressure through different pathways and are often combined. Diabetes treatments may also protect the heart and kidneys in appropriately selected people. Antiplatelet or anticoagulant drugs can prevent clots in specific settings, but can cause bleeding. Aspirin is therefore not a casual preventive vitamin for everyone. Real management balances likely benefit, possible harm, affordability, preference, and sustained follow-through. Recovery after a heart event is not a return to the person who existed the day before. It is a passage through fear, healing, new medicines, and a changed understanding of the body. Cardiac rehabilitation combines supervised activity, education, risk control, and psychological support. It can rebuild confidence while lowering the chance of future complications. Depression and anxiety after heart disease are common and deserve direct care, not quiet dismissal. Families may also need guidance about symptoms, medicines, food, activity, and emergency plans. Follow-up catches side effects, recurrent symptoms, changing pressure, and signs of fluid overload. Progress may look like a longer walk, steadier breathing, improved tests, or simply another ordinary morning. The aim is not invulnerability, because no treatment can promise that. The aim is a safer future built from evidence, attention, and decisions that can endure. Now return to the heart at night, beating unseen beneath ribs and sleeping streets. Its rhythm carries ancestry, environment, illness, treatment, chance, and every accumulated year. Heart disease is neither one monster nor one personal failure waiting to be exposed. It is a family of processes, some sudden in appearance and many slow enough to interrupt. The scientific reveal is hopeful precisely because it is not magical. Pressure can be lowered, LDL reduced, tobacco left behind, fitness built, and diabetes managed. Dangerous structures can sometimes be repaired, and chronic disease can often be controlled for years. Uncertainty remains in inflammation, genetics, metabolism, and the risks our current tools cannot see. But prevention begins before certainty, with measurements, support, treatment, and one repeatable next step. Each beat is brief, yet across a lifetime those small interventions can rewrite the ending.